Good evening. My name is Karen, and I'm a Community Education Coordinator for Boulder Community Health. I'd like to welcome you to tonight's lecture on latest treatments for heart valve problems. I'd like to go over the format for the lecture. The lecture portion will last about 40 minutes. Afterwards, we'll use the remaining time for questions. Type your short, general question in the chat box below the video on your screen. We'll get to as many as we can. Please bear in mind that speakers are not able to make diagnoses or give specific medical advice in this format. On behalf of Boulder Community Health, it's my pleasure to introduce this evening's speaker, Dr. Srini Iyengar. Dr. Iyengar is a board-certified cardiologist who is fellowship trained in cardiovascular medicine and interventional cardiology. He attended medical school at Ross University with subsequent internal medicine training, including a year as chief resident at the Jewish Hospital, University of Cincinnati. He then completed a heart failure and transplantation fellowship and a general cardiology fellowship at The Ohio State University. This was followed by a 2-year advanced interventional cardiology and structural fellowship at Columbia University. Dr. Iyengar is the structural heart director at Boulder Community Health, and he sees patients at Boulder Heart in Boulder and at Erie Medical Center. Welcome, Dr. Iyengar.
Well, thank you for the introduction, and thank you for everyone at home tuning in right now for this talk. My name again is Srini Iyengar, and I'm the Director of Structural Heart here at Boulder Community Health. And with that, I'd like to start with our talk, which is the latest treatments for heart valve problems. So, background. Historically, a number of cardiac conditions could only be treated with open heart surgery. Given the increasing age of our population, in addition to the multiple comorbid issues involved, the risk of complications of operating on this population has also gone up. Medical technology has made leaps and bounds in the last decade in regards to treating cardiovascular disorders. So 30 years ago, use of coronary balloons, it's called PTCA, followed by stents, revolutionized heart attacks, which is also called acute coronary syndromes. Pacemakers implanted without open heart surgery changed the dynamic of heart rhythm disorders. The one major area, however, that was not successfully addressed, structural heart. Example, the valves of the heart, the appendage of the heart, and in the last 10 to 12 years, we've seen major changes. So there's been a structural heart revolution. Revolution, not just evolution. We now have the capability to address serious internal cardiac issues with minimally invasive techniques. Results with certain procedures have now shown to be equivalent, if not better, with certain conditions than surgical standard of care. And this movement only seems to be gaining strength with newer technologies entering the cardiac arena every year. So with all the cardiac pathology that's out there, for the scope of tonight's talk, I'm going to focus on two distinct issues. The first one is called mitral regurgitation, the mitral valve being one of the 4 cardiac valves, and regurgitation being a leaky valve. So this condition is called mitral regurgitation, which means a leaky mitral valve. It affects thousands of Americans, vastly undertreated, and basically means the mitral valve has become leaky. Blood spills backwards into the lungs rather than going forward into the left ventricle as a result of a weak or degenerated mitral leaflet. It results in progressive shortness of breath, fatigue, and eventual heart failure. So what causes this leaky mitral valve? Well, we have 2 major classes of mitral regurgitation, or also called MR. One's degenerative and one is functional. Degenerative is usually due to an anatomic abnormality in the mitral valve itself, including the leaflets or the apparatus around it. Functional MR, which is also known as secondary MR, is a result of the left ventricle, the bottom chamber, getting dilated, which can stretch the valve out and make the valve leak because it doesn't actually close properly. Moderate or severe valvular disease is common and increases with age. MR, mitral regurgitation, is the most common type of heart valve insufficiency in the US, and it increases with age. And as you can see, it basically at this point in time, as we all get older, develops some essence of it. And it's not just because of the valve, but all the reasons which we will talk about, including high blood pressure. If you don't treat MR, mitral regurgitation, it can progress to heart failure. It's a vicious cycle because once you start having leakiness across the valve, the chambers in the heart start dilating. Once the chambers start dilating, the heart has to work harder to pump that blood forward, causing more changes in the heart muscle. And this vicious cycle leads to the changes and dilatation of the left ventricle, which basically initiates a cascade of events, eventually leading to heart failure and, of course, death if untreated. So what are the treatments for MR? Historically, only medical therapy followed by surgery, if possible, were mainstays of therapy. Medical therapy could be very effective in cases, but it cannot reverse a torn or degenerative mitral valve leaflet. Surgery is the gold standard and still is. However, surgery can be high risk in certain populations and needs to be done by a surgeon or surgeons with the skill experience to perform a mitral valve replacement or repair. With that being said, why aren't we always saying medicine first and then surgery, or surgery first, medicine? Well, each patient is going to be individual. Medications, again, like diuretics, something called Lasix or furosemide, water pills, can help people who have fluid retention. Blood pressure control can help manage a leaky valve. But these medications can only work so well for so long. Surgery, again, is the gold standard. However, a number of patients are just too frail, old, or have other risk factors that they cannot get surgery. So we had a gap between medications and surgery for the longest time. And what has developed in that space are percutaneous or minimally invasive therapies for this particular condition. And the one system that has become the mainstay or the gold standard for this is called the MitraClip system, which is basically a percutaneous mitral valve repair by creating a vertical line of coaptation. Basically, that means you are aligning the two leaflets together, forming a double orifice valve. And I will show you an animation of this device being utilized. But again, with this device, what we have found historically in the last 15 years, that there's been successful outcomes for patients and centers doing this therapy. So for the right patient, this therapy can be very beneficial. And with that being said, I'm going to show you the animation of what this device looks like and how it functions. This is the device when it's open outside the body. But as you can see here in this animation, we have a beating heart. And in the heart, as we mentioned before, there are valves. And here in this schematic, you can see where the chambers are located. And what we're seeing here is blood coming from the lungs, and the top right corner is the left atrium pumping into the left ventricle. And that red is blood going from top to bottom. And this is a normally functioning heart. But as time goes on, what we can see here, and this is the mitral valve that's being labeled, if it does start degenerating or not functioning appropriately, we'll see that the blood that's being pumped, normally in this case, can result in the blood actually going the wrong way. So in this particular animation right now, the blood is going normal. We're seeing the normal flow of top to bottom to the aorta out to the body. And there, what looks like almost like a volcano shooting up lava, that is mitral regurgitation. That is blood going backwards from the ventricle to the atrium. So that volcano-like spew is actually blood going backwards. And the rationale of what's going on is showing you there. One is a degenerative situation and one is a functional. Both situations obviously can lead to the leaking of that valve. This is a microscopic histologic evaluation of the leaflets themselves, showing you how they stretch and get deformed with this condition as time goes on. Into this situation, if a patient is not deemed to be an adequate surgical patient, the MitraClip system. This system that you see here is basically outside the body, and the only thing that goes into the body is the thing on the left, which is the cable with the clip itself. So we place a sheath into the common femoral vein. Through the vein, we will come up to the heart with the catheter, and we make something called a transeptal puncture, going from the right to the left side of the heart. Patients do not feel this, and this hole will close up after we remove the sheath from that area. We then place the catheter into the left atrium, pull the wire and the dilator back, and introduce the MitraClip in the closed form. This device has the ability to articulate or angulate in numerous different degrees. Once we have found where we like to cross this valve, we will open it up, position appropriately under echocardiographic guidance, and we will place the clip across the valve. Once the clip is across the valve, we will start closing it down and cinch up on the leaflets. Once we put the clip in place, we re-examine to see how our placement is. If we like our placement, then we will confirm on our echocardiographic imaging. However, as you see here, there looks like there's still that spout of lava that's coming through. We may need to move the clip, and we can do that. We will then move the clip to a spot that we prefer, and if once we do like the positioning, we deploy the clip. And this is a permanent deployment, as in this is a device that will not be removed or replaced as time goes on. There's no animal product in the device, so it does not degenerate. With that being said, and for the sake of time, I'm going to move on to our second valve discussion, which is the aortic valve. And instead of a leaky aortic valve, I'm going to talk about a calcified or tight aortic valve called stenosis. So this is called aortic stenosis, aortic valve stenosis to be specific. So AS can be seen earlier in life as a congenital issue, either a two-leaflet valve, which is called bicuspid, but is more often seen as a calcific age-related issue. It's a very real problem in the US. It results in closure of the aortic valve, which causes progressive chest pain, lightheaded spells, passing out spells, and eventually heart failure and death. The prevalence of AS, it's estimated to be in 7% of the population in the US over the age of 65. It's more likely to affect men than women. 80% of adults with symptomatic aortic stenosis are male. What are the demographics? Well, for pure aortic stenosis, 2% of the US population over 65 years old has it. Sclerosis means there's scarring or calcification of the valve, but hasn't yet stopped it from opening. That's nearly 30% of the population over 65. And we do know that sclerosis can lead to stenosis as time goes on. So what causes this? And it's not by too much milk in your diet or calcium in your diet. Unfortunately, calcific aortic stenosis is more age-related, and we see this in a situation where patients over the age of 65, it's just calcium deposits associated with aging, not necessarily anything with diet. Rheumatic fever. If you had rheumatic fever as a child, you can develop this condition as you get older. And of course, like I mentioned earlier, congenital abnormalities, the two-leaflet valve called the bicuspid valve. These issues usually we see at the earlier ages of life. Sometimes the stenosis presents in the 5th or 6th decade of life, as opposed to the calcific. So what are risk factors? Like we mentioned, the male gender, increasing age, high blood pressure, smoking, elevated LPA, and elevated LDL cholesterol. In short, these risk factors are risk factors for all types of cardiovascular disease. So I would never look at these as being specific to aortic stenosis, but rather disease progression of vascular disease in the body. All of these contribute to it. So aortic stenosis is a life-threatening and progresses rapidly when symptoms develop. So that's the key point. You can have aortic stenosis for your whole life, or say from age 30 to 80 with no problems. But the clock ticks once symptoms develop. Once people start having fatigue, shortness of breath, lightheaded spells, secondary to the valve, it progresses rapidly. As you can see there, once symptoms happen, there's a rapid progression of issues involving the heart. So we want to catch patients early in the process. We are looking for patients who are manifesting symptoms early, and current studies have even stated maybe we should be looking at more asymptomatic patients as well, which is, again, is a brand new kind of school of thought. But again, what we don't want to do is miss the boat. We don't want to not catch patients before they're in the ER gasping for breath or having chest pain in heart failure. Sobering perspective, if you look at a lot of the cancers that are out there, they have better 5-year survival than severe inoperable aortic stenosis. So when we saw this slide, this is an older slide now, but this was very eye-opening to the cardiology community. We really didn't have therapies for aortic stenosis. And to be very honest, medications don't really work. When you have someone with a valve that's not opening, that's mechanical, medications don't really change the mechanics of a valve. So really what you need to do is to replace it. Now here's the catch. Surgeons would look at these patients oftentimes and say, well, these severe calcific aortic stenosis patients are in their 80s or 90s. They're not good surgical patients. Hence, we really didn't have much to offer. And when patients hit this point of life, palliative care was pretty much the standard. We didn't have much to offer other than super high risk surgery. So just like with the mitral regurgitation example, we had medications, surgery, but not much in between. We, as a field, developed things that would fit that role, potentially for patients who cannot get surgery, and now, as I'll explain later, for more walks of life past the people who just can't get surgery. So aortic valve replacement, we know, improves survival. So surgical aortic valve replacement, this study was done some time ago, but if you catch the patients early in the process and replace the aortic valve, they do great. They do much better than patients who get nothing. And obviously, the patients who are symptomatics basically can really benefit from getting the surgical valve replacement. So this is an older study, but just show the point that watching and waiting medications don't do enough. You need to fix that valve. But there's a low percentage of aortic valve surgery. Studies show at least 40% of patients with severe AS are not treated with a surgical AVR. Why is that? Historically, because these patients were older when they were diagnosed with this condition, and they were thought to be too high risk to have open heart surgery. So, in short, aortic valve replacement, open heart surgery becomes riskier with the older population. The need for longer hospital stays, rehab, and treatment of comorbid issues are major factors. The last 10, if not 15 years has been a revolution in aortic stenosis therapy. TAVR, transcatheter aortic valve replacement, has become a viable technology in the treatment of aortic stenosis and has, if anything, become more of the standard of care in a number of patients as well. So what is TAVR, transcatheter aortic valve replacement? It's an aortic valve replacement as an alternative to traditional thoracotomy. It's less invasive than traditional thoracotomy for patients considered too high risk for traditional surgery. This is the initial studies that were done on this valve. This slide actually will need to be updated because now patients who are not just high risk for surgery, patients who are intermediate risk, low risk, pretty much any severe symptomatic aortic stenosis patient can be considered for this procedure as long as a cardiologist and a surgeon have been discussing this procedure in this case with the patient. So it is a team effort. We never do these procedures by individuals. It's always a team involved. So currently, there are 3 TAVR options available in the United States. There is the Edwards Sapien valve, which was the original valve that first came out in 2007, which I was lucky to be part of this trial when I was at Columbia University. There is the Medtronic Evolut FX Plus valve, which has the best long-term data of any valve that is currently on the market. And the most brand new valve that has just been released in the last 2 years is called the Abbott Portico TAVR or Navitor. And this is only for high-risk inoperable patients, so it has not yet been approved for all risk scores. So I'm going to talk about the Medtronic Evolut FX Plus valve. It has excellent results from multiple studies from both approved valves. But the Evolut has recent studies have shown better results in high-risk patients receiving a transfemoral Evolut as opposed to open heart surgery. So the question of long-term durability is still being examined. I get this question all the time from patients. Why can't I just get a TAVR? Why do I have to get open heart surgery? Well, we have 6 to 7 decades of experience with open heart surgery with valves. TAVR is a procedure in the United States that's only been approved since 2012. So we barely have 14 years of experience. So it's hard to tell someone that you're going to get X amount of years out of the TAVR valve versus a surgical valve that we have pretty good background data on. So it's important that we take all of these factors into play before we just take the easiest plan or easiest procedure. That's not always the best answer, and especially if patients have other issues like other valve disease or blocked arteries that might need a bypass or another valve procedure to be done. So this is the animation of the TAVR procedure with the Evolute FX TAVR valve. This is a normal looking aortic valve, and this is an aortic valve that has gotten calcified. See the white plaque type material that's restricting the motion of those leaflets? So for this particular procedure, it can be done under local conscious sedation, MAC anesthesia, general anesthesia, depending on the risk factors of the patient. Our plan is to access, in majority of the cases, the arteries in the femoral or groin regions, which is usually the easiest highway to get to the heart from the perspective of putting this valve in. There are other ways to access the heart. And that first one there is a femoral. There's one in the neck called the subclavian or carotid artery, or we can go between the ribs itself. But this is the most common route of entry, which is called the femoral artery. Once we access that artery, we'll advance this catheter with the device over a wire. The wire is in the ventricle. Once we have placed this valve across, we literally unfurl the valve. And the beauty of this valve is it can be moved before full deployment. And once the valve is deployed and we're happy with the positioning, we can then release it. And the valve is working immediately. There is no sutures, there's no glue, there is no issues of keeping the valve in place. Your own native valve will keep the cement, basically, to keep this new valve in place. And this valve at this point is completely functional. So in summary, heart disease, valve disease is growing in the US population. We need alternatives to standard surgical therapy because there are a number of patients who cannot get standard of care surgery like 30, 40 years ago. Both TAVR and MitraClip represent the forefront of these therapies, but I guarantee you, they're certainly not the last. And with that, I'd like to, once again, say thank you for tuning in tonight, but I'd like to introduce some new colleagues of mine. On the bottom left, there's Dr. Chauhan, who is my new interventional cardiologist colleague who also performs structural heart procedures here at BCH. I also have two new surgical colleagues, Dr. Brent New and Dr. Joseph Rowe. And in the middle there, obviously, is our chief of surgery, Dr. Brian Mahan. Together as a team, we evaluate all of these patients and determine which direction is the best for the patient, whether it be open heart surgery, whether it be TAVR or MitraClip, or whether it be just medications. But again, it takes a team to treat every individual patient. And with that, I'll just say thank you.
Thank you very much, Doctor. That was very informational. And we want to remind our audience at this time is we're available for questions. And please put your general question in the chat box below the video on your screen, and we'll get to as many as we can. We do want to remind you to please keep your questions general and bear in mind that speakers are not able to make a diagnosis or give specific medical advice in this format. And in no particular order, you had mentioned some symptoms for to trigger how you know about both of these issues. Can you refresh the audience's information on what the symptoms are and how you even begin to catch this?
So the biggest issue with these valvular problems is recognizing what your body is going through. So I like to say oftentimes it's not the dramatic textbook chest pain, shortness of breath that is a red flag. If you are noticing more fatigue in your day-to-day activities, not just once in a while, but noticing a slowing down of fatigue levels that are developing. Those are things not to be seeing a cardiologist, but rather your primary care. Figuring out, is it something else? Is it, something am I anemic? Do I have my thyroid checked? Do I need to do something else? The second part of this is your physician putting a stethoscope on your chest and listening. Hearing the murmurs or the whooshing sound inside the heart can oftentimes reveal these valvular abnormalities. So if someone should say, I am really getting more fatigued, or I can't walk up the stairs like I used to, maybe I'm just getting older, having your doctor listen to you and saying, wait, I'm hearing a murmur or I'm hearing a sound, then getting you referred for something called an echocardiogram, which is an ultrasound of the heart, leads you down the path for further diagnosis.
Okay. Sounds good. Thank you. Is the electrophysiology department the group that diagnoses these conditions?
So electrophysiology, and I like to joke with my patients sometimes, I tell them I'm the plumber, they're the electricians. So basically I deal with all the plumbing issues, whether it be blocked arteries or blocked valves. Electricians, electrophysiologists, deal with primarily arrhythmias called atrial fibrillation or SVT or VT. These are things that are electrically going on in the heart, and the electrophysiologists specifically deal with that condition. They can diagnose these valvular heart conditions, but their primary role is more on the electrical side. When it comes to the valvular issues, it's more the surgical and structural side.
And then how would you know that?
Well, most likely the electrophysiologist, like any physician, would be listening to you, just like I mentioned. The history, the physical exam are the first things that any physician should do to make the diagnosis, or at least getting more testing.
Would the primary care be able to direct the patient to the correct person?
Well, I would say the primary care doctor should be referring, if there's any question of cardiac issues, to the cardiology group. There's no reason to go right to the surgeon or the electrophysiologist. The good news is at BCH here at Boulder Heart, we have a number of cardiologists that see all types of patients. So that would be the first line of defense or first line of therapy.
Okay, that helps clear that up. Thank you. Would the clip you discussed be effective for tricuspid regurgitation as well?
Well, that's a great question, and we are utilizing it, but not the MitraClip. It's called TriClip. There is actually a device specifically for tricuspid regurgitation that we utilize as well.
Okay. Does it work similar to the one that you went over?
Exactly. It actually, except the difference is it's a different device in the sense that it's made specifically for the tricuspid valve. But yes, it is very similar in the animation and the graphics that I showed for the mitral valve.
Thank you. Are there any holistic supplements that can help?
Unfortunately, there aren't. If these are mechanical problems, now, I will say if someone has a leaky mitral valve due to high blood pressure and there's a way to get blood pressure down holistically, that would be your best bet. But unfortunately, that's the minority of the cases we see. Oftentimes, the valve is damaged. When a damaged valve is present, no type of any medication, pharmaceutical or non-pharmaceutical, can usually reverse that from getting worse.
Okay. If your leaky valves are just moderate, the mitral and tricuspid clips, can they still be considered?
So normally no, because these clips are utilized in the severe symptomatic leaking patients. So severe symptomatic tricuspid or severe symptomatic mitral, only for the sake that we do not want to start placing procedures or doing procedures on patients who don't have overwhelming or really clinically symptomatic valve disease. So it's important to understand that right now, when we see patients with moderate disease who are not symptomatic, we will oftentimes monitor these patients very closely with a repeat ultrasound in 6 months from their initial diagnosis.
How fast does it progress?
Individual persons can change. I mean, it's impossible to tell you that everybody will go at the same rate of deterioration or having symptoms. It's important that's why each patient has to be individualized. Example, if someone is having sleep apnea and high blood pressure, versus someone who doesn't, I would suspect that patient who's untreated would be progressing much faster than someone who wasn't.
Okay. Is there an average age where heart valve problems tend to begin to arise?
There isn't an average age per se because there's 4 heart valves and there's different conditions for each valve. For aortic stenosis, however, when we call it calcific aortic stenosis, we generally see patients in their 7th and 8th decade manifesting symptoms. If you have a bicuspid aortic valve, which is something you were born with, a congenital issue, if that becomes stenotic, we see that more in the 5th and 6th decade of life. So it's a little younger than the population of the calcific aortic stenosis.
Okay. We will try this one. It might be a little specific, but let's see your take on this, please. This person has a MV regurgitation with severe prolapse. Their doctor says that if they have surgery, you want your valve fixed, but not replaced if possible, in order to have the best outcome. Is that the same treatment as the MitraClip, or it's something different? And which one is better?
So number one, I would say the best therapy for invasive therapy for mitral valve disease is surgery. Surgery is still the gold standard. So surgical mitral valve repair is the best therapy that I would say for any given patient who has valves that can be repaired, because it keeps the anatomy secure in the heart. If that valve cannot be repaired, then either a mitral valve replacement, which is surgical, versus a MitraClip procedure are alternative. Now, again, I firmly believe that the MitraClip procedure is very useful, but it is not equivalent to a good surgical mitral valve repair. So that's why, patients who have this condition, you have to see a team. It's not a one-person situation. We really need to have all opinions prior to doing any invasive procedure.
That's good to know. Thank you. How often is a pacemaker placed in the heart?
That is a very generic question. Unfortunately, I cannot answer that because it could be for 1,000 different reasons. A pacemaker can be placed for bad or low heart rates or dysfunctional heart rates. It can be placed after surgery for dysfunctional heart rates, so it's impossible to answer that question.
Okay. Is that something that your team assesses as well?
We do, but there's no way to predict who is going to get this exactly. There are other conditions. This is an entire different topic of discussion about who gets a pacemaker, because it's more of an electrical issue than structural.
Thank you for that clarification. Can MR for MitraClip be accessed after TAVR?
Can MR after MitraClip be accessed after TAVR? Yes, you can fix mitral. Yes, you can. You can fix the mitral regurgitation after TAVR because it is a different valve, and the access to the mitral valve is different than you do for TAVR.
Okay, so two separate things.
You can do this, exactly. And I have done that before, where we've placed a TAVR valve, and a few months later, if there was reason, we would go in and then fix the mitral valve.
Okay, thank you. Can the new aortic valve replacements be used if a patient has an existing bovine aortic valve replacement that is beginning to fail?
Yes, it can be, and we do this. Now, here's the catch, though. If a patient has a surgical valve that's deteriorating, majority of the time, we can put a TAVR valve in that. However, I will caution putting a TAVR valve in a surgical valve unless I know that the patient itself cannot get a repeat open heart procedure. So we have some patients who are young who've gotten open heart surgery when they're, say, 20s and 30s, and they are now in their 50s maybe having problems. That patient potentially should be getting a repeat open heart surgery, because we don't want to keep putting valves in old valves as a person is getting older, because again, the complication rates will go up as they get older. So TAVR can be done in these surgical valves, but they're reserved for patients who really aren't good repeat surgical candidates.
Thank you. This person has congestive heart failure and pulmonary hypertension with mitral valve leakage. Are they a candidate then for valve replacement?
Well, it all depends. Other than those facts, we would have to know a lot more. as in the numbers, how bad is the heart failure, how high is the pulmonary hypertension, and how much is it leaking. So these are all factors that have to be taken into account. And then how do they feel? Because if someone feels great and they have some of these conditions, we wouldn't necessarily jump in there for any procedure.
All right. Is mitral valve prolapse the same as mitral regurgitation?
It is not the same as mitral regurgitation. Basically, mitral valve prolapse means that the valve itself is kind of bending on itself when it's bending, when it's going up and down. And that condition is historically was well documented and diagnosed about 40 to 50 years ago. It seems that was a very common diagnosis. It does lead to potential regurgitation, but you don't need mitral valve prolapse to have mitral regurgitation. Mitral regurgitation is very generic in the sense that it means a leaking valve. Mitral valve prolapse is just one type of potential mitral regurgitation.
Okay. What might make someone not a good candidate for a mitral clip?
So if someone has mitral stenosis, just like I talked about the aortic valve, so if someone has calcium on their mitral valve that's limiting the opening so they can be leaking and calcified, they would be bad or not good candidates for MitraClip, because then you can make that stenosis worse by putting a clip there and preventing the leaflets from opening. So that's another reason why certain patients, surgery is still the better outcome for them, because then in that case, the surgeons can take those valves out and put a new one in. So if a patient has calcium across their valve, their leaflets, or the leaflets aren't opening well, they would not be a good candidate for the MitraClip.
Okay. This person has a lot of PVCs. When should they become concerned?
Well, to be honest, PVCs are premature ventricular contractions. They mean extra beats. To be honest, there's patients I have who have thousands of these a day and never have a problem. I have other patients who have 100 of them and feel every one. So it all comes down to symptoms. If you feel these extra beats in your chest or the skip beats, that's the time then to get further evaluated, because sleep apnea, low potassium, low magnesium are all things that can cause PVCs.
Okay. What is the reason why you go into the carotid artery instead of the femoral access for TAVR?
We would do that only if the femoral access isn't suitable. So if someone has a blocked femoral artery or very narrowed or calcified femoral arteries, the way I describe it to patients is this: when you're riding down the highway, driving down the highway, if there's potholes, you're going to try to take an exit to get around it. And that's kind of how we look at it from the access points of the body. If we know there's a lot of areas of the aorta or the femoral vessels which have blockages or narrowing, I'm not going to just try to run through those potholes. I'm going to find a different way around. And the carotid artery is a different way around. Now, it's a little bit more invasive because it does require one of our surgeons to make an incision in the carotid artery versus the femoral artery, which is more just placing a catheter. So it is more invasive, but the results are phenomenal with either side. So we would choose the femoral because it's less invasive to the patient, but we will clearly go carotid if we need to.
Okay, thank you. If your MV regurgitation is improving because of medical interventions, is there a way to predict how long that will last, or is it inevitable that you're going to need to have an MV repair or replacement?
Well, no, because if your mitral valve regurgitation is getting better with therapy, and hopefully that means blood pressure therapy, because if you have an uncontrolled hypertension and you get that blood pressure down to normal and you see no more leaking across the mitral valve, as long as your blood pressure is controlled, theoretically, you're not going to need something for that mitral valve. What I would suggest for those patients is usually every 6 months to every year, repeating the ultrasound of the heart to make sure that nothing has changed. But as long as the medications are doing their job and reducing that leak, which is, again, usually related to blood pressure, there shouldn't be a reason to think that patient will eventually have to get a mitral valve replacement.
It's good to know. Thank you. What determines the strength of the heartbeat?
So again, you can look at it from numerous different ways, but usually what we say the strength of the heartbeat is the muscle contraction. And that's really what it comes down to, that the muscle itself is contracting normally. And as long as we can see that on the ultrasound, of course, blood pressure, heart rate are part of it, but seeing how the muscle is looking on the echocardiogram is usually the best determinant of knowing how strong the contraction is.
We want to let our audience know that we do have time for more questions. So if you do have some questions, please put that in the chat box below the video on your screen. So a couple of questions here. Do you stop the heart during TAVR and MitraClip?
So during MitraClip, we do not do anything electrically to the heart. And during TAVR, we don't really stop the heart, but rather we actually speed the heart up very fast to the point where it doesn't contract as hard as it would at normal. So we basically put a temporary pacemaker wire and increase the heart rate temporarily for about 5 to 10 seconds to a really fast rate so the heart can basically stay almost still while we're deploying the valve.
Interesting. Okay, thank you. So for these procedures, can you tell the success rate and hopefully not very many fatalities?
We can't tell, obviously, before the procedure for each patient, but we have generalized statistics for who would be a good candidate and who isn't. And to be honest, I've been doing this for such a long time. Numbers are one thing, but I can tell by talking to patients and their families who will generally do better or not with certain procedures based on their comorbid issues. If they have on oxygen with kidney failure, with lung problems, those patients won't do good with any procedure. So those are higher risk. But that's not something that we can't do. It's just that everyone should be understanding of the risks before you get in the room to do the procedure.
Okay. But the procedure themselves, once you assess those risks, what is the statistical safety on that?
Again, I would say very high. I'm not going to give a number because each person is individualized. So I think it wouldn't be appropriate to say 99% success if each patient is individualized, because each person comes in the room with a slightly different risk factor profile.
Okay, thank you for that clarification. Is there a medicine that will slow down or get rid of calcification and plaque?
So there's no real medication that will get rid of calcification plaque on the valves. But we do have medications like there are statins, Lipitor, atorvastatin, Crestor, rosuvastatin, that slow down progression of inflammation in the coronary arteries and vascular beds. So there is a lot of research being done right now to see, are there medications that can actually reduce calcification on the aortic valve? And that's still ongoing and a hot button issue, but nothing has come out yet that can say, hey, I have aortic stenosis, let me take this pill, get rid of the aortic stenosis. That's not yet ready.
Or just for plaque in general?
The only thing that can stabilize plaque that we have is currently the statin medications and something called the PCSK9 inhibitors, which are injectable medications. Repatha or Praluent are the most common ones we have, but they're stabilizing plaque. They're not necessarily regressing it.
Okay, thank you for that clarification. I hope there's some tests that are going to come forward with that.
I assume in the next 10 years, we'll see a lot more changes.
Is MV regurgitation valve repair open heart or orthoscopic?
So there is multiple ways of fixing the mitral valve, and general open heart surgery obviously is one of them, but there are robotic and minimally invasive ways of performing this mitral valve repair. Thankfully, here at Boulder, we actually have surgeons that can do the minimally invasive repair as well as the traditional open heart surgery. But yes, there are different ways of fixing the valve.
Okay. What effect does cardio exercise have on a leaky valve?
So when it comes to valvular heart disease, especially ones that have degenerative issues in the valve themselves, exercise does not necessarily improve issues in the valves, but what it does though, it helps the physicians understand symptoms. Now, if you're just sitting on the couch watching TV all day and you have severe aortic stenosis, it's very difficult to tell you how symptomatic you are. So exercise in that way does help the clinicians and the patient to understand, hey, I'm being limited by something. What is limiting me doing what I want to do? And if that is the valve, then it makes the diagnosis flesh out much quicker for us to deal with.
You may have answered this in another question, but I'll put this out here again for you. Do you perform TAVR with ascending aorta repair?
So TAVR is not performed with any other concomitant surgical repair. Ascending aortic repair is an open heart surgical procedure. So they can do a valve replacement, a surgical valve replacement with an ascending aortic repair, but not a TAVR with an ascending aortic repair because those are different procedures.
How far apart can you do it?
Well, normally we wouldn't, because truthfully, if a patient is getting an ascending aortic repair, they should get their valve fixed if they needed to at the same time.
Okay. How does sleep apnea affect the heart?
So sleep apnea is definitely one of the most undiagnosed and I would dare say one of the most unpopular conditions because no one wants to admit that they snore at night, and if they do snore, they refuse to use the CPAP. I'm going to tell you as a cardiologist who sends all my patients to my pulmonary colleagues here at BCH for sleep apnea workups, please get checked out because sleep apnea basically means when you're sleeping or theoretically at night when you're laying down and you're thinking you're sleeping, you're not getting enough oxygen to your body. And what happens is whether it be the brain or the lungs or the throat, some part of the communication, oxygen isn't getting there. And so the heart goes into overdrive trying to get more oxygen pumped around the body. So it's like you're sleeping, dreaming at night, but your heart's running a marathon. Hence, when people wake up, they feel like they have to take a nap during the day or they're feeling really dragging and fatigued. So sleep apnea is one of those situations where if untreated can lead to heart failure. It can make the heart work so hard, you can go into atrial fibrillation, have PVCs, have the heart dilate. So it has a host of negative conditions. And if you can tolerate the treatment, which is the CPAP usually, it works wonders.
Thank you. With COPD and aortic stenosis, what is the treatment and surgery?
So COPD, depending on the severity, COPD, chronic obstructive pulmonary disease, can be very, very serious if it's later stages, which means that the patients cannot breathe properly. And if you add aortic stenosis to it, it's a double whammy. So patients who have moderate to severe COPD are oftentimes better candidates for TAVR because there's less anesthetic or general anesthesia utilization and they can get through the procedure quicker. That doesn't mean every patient with COPD gets TAVR. It just means that the lung conditions definitely influence our choice of procedure for these particular patients.
Okay. So you mentioned two procedures in your talk tonight. Can you talk about if the insurance coverage as well as this person wasn't sure if this was part of it as well. You had mentioned some solutions with open heart surgery, if that was covered by insurance.
So normally insurance will cover all of these procedures because they're all FDA approved and approved by Medicare as well. So these are not procedures that are experimental. They're not investigational. These are approved procedures. So if a patient meets criteria, that's why it's so critical, though, that we don't just offer a procedure right when you walk in the door. There's certain mandatory consults and documentation that has to be performed by the physicians and the team seeing patients. But yes, when it comes to insurance, these procedures are covered and it's not experimental or investigational. Whatever I talked about tonight is exactly that. It's basically standard of care medicine.
Nice to know. Thank you. For each of the procedures, how long do they take?
So the TAVR procedure can take, on average, about an hour and a half. And patients usually stay one night in the hospital, and that's generally it for most patients. Some people will stay 2 nights, but usually it's one night, and the procedure itself about an hour and a half. MitraClip can take a little longer, I would say 2 to 3 hour procedure, but the same thing, one night in the hospital is the routine for most patients.
Okay. And kind of along with that, what is the recovery time and any future limitations?
So recovery for MitraClip and TAVR is usually quite quick because it's really just going through the groin or the artery in the neck with an incision or a small insertion of catheters. So usually 3 hours of bed rest is what we say for most patients. But that afternoon or evening of the procedure, I want them out of bed, moving around, walking the halls, and keeping them overnight just to watch, make sure everything's okay. Next day, they're usually discharged. And for 1 week, we tell the patients, not to get into hot tubs, not to necessarily do anything to compromise the groin areas. But after 1 week, we get them into cardiac rehab as an outpatient, and they're back to their baseline.
Is cardiac rehab the same thing as PT?
No, PT, physical therapy, is different. Physical therapy usually comes to the home, or there is basically specific physical therapy requirements. Cardiac rehab is a very generalized situation where we have cardiac specialist nurses who basically observe and help patients utilize exercise equipment and exercises post open heart or post TAVR procedures.
Okay, thank you. Doctor, is there anything else that you would like to clarify or expand on about the presentation tonight?
Well, the big thing for everyone is these procedures are, I would say, because in my world, I do these procedures, I think are amazing. However, these procedures are not for everyone because there are procedures that are required for certain patients versus others. So the easy way is not always the right way. Hence why it's best to see the physicians that have the complement of all of the procedures at their disposal. One of the advantages here at BCH is that we not only have the traditional open heart surgeons, we have the minimally invasive surgeons, and we have obviously the structural procedures. We have it all under one roof. Everyone is in the same hallway with each other. So the conversations that we have and the discussions we have with the patients are all transparent. So it's important to understand that because when you have one of these conditions, you want the most honest, ethical opinion, not necessarily the easy opinion. So it's really incredible to understand that, yes, we've made advances in medicine, but sometimes open heart is the right answer. And the truth is you want to have all of that at your disposal, and basically you want to have the consultations available when you need them. And that's something I'm proud to say we have here at BCH.
Thank you for that. We have come to the end of our lecture. A recording of tonight's lecture is available at bch.org/livestream. You will receive a post-lecture survey by email. Please take a minute to fill this out. Thank you for joining us and have a good night.